Well, we'll just wait for a few seconds, Senator Ravalia, until people can log in, and then we'll have a chance to start. Is that okay with you?
Yes, absolutely. Look forward to it. Thanks.
Awesome, awesome. So maybe about 10 seconds more. I know that it isn't always easy to log on to these electronic devices, even though we've been so accustomed to doing it for quite some time now.
Yeah. The mute button seems to be the mystery.
That's right. The famous 3 words, you're on mute. Well, why don't we start then? Welcome, everyone, to the first of our series for this upcoming Mental Health Week on integration of quality mental health care into primary care across Canada. And I'm so pleased to welcome my friend and colleague, Senator Dr. Mohamed-Ravalia, who I've come to know during our sojourn together in the upper chamber. And I don't know where you've been all my life, Senator Ravalia, but I've come to know you as a great colleague and a friend. And Senator Ravalia is a family physician who's practiced in Zimbabwe and in Newfoundland. And he's had a long and distinguished career. Prior to the Senate, he's received the Order of Canada for his incredible accomplishments. People might know me. I'm a psychiatrist. I've worked for over 20 years in many different countries. And I've seen the importance of integrating mental health care into primary care. And I've seen the challenges that siloed mental health care have for access to quality care. You know, in 2008, the World Health Organization and WONCA, the World Organization of Family Doctors, at a historic moment, released a report called Integrating Mental Health into Primary Care, a Global Perspective. It recognized that there were substantive rates of mental illness in the population, about 13%. It noted substantive morbidity with mental illness and other illnesses such as cancer and Parkinson's, etc. But it also noted there was a huge gap between the need for high-quality mental health care and its availability. And they came up with a solution. And they said that it was essential that we fully integrate high-quality mental health care into all of primary care. That primary health care is the foundation of our healthcare system, and we need to stop treating mental health care as a separate silo. Many people with mental health care needs can have those effectively treated in primary care without having to enter the secondary or tertiary care systems. And because family care providers have 5 things that they can do around families. They monitor families, they can promote good mental health, they can apply preventive strategies, they can identify mental illnesses early and provide effective treatment. So why wouldn't we have fully integrated mental health care into primary care? So, Dr. Ravalia, Senator Ravalia, you have done this work for your whole life, and you've thought long and hard about it. You advise people. What are your thoughts, and what are your thoughts about mental health care?
Thank you very much, Stan, and welcome to all our guests online. So, you've raised some very critical issues. In my role as a primary care physician, a substantial proportion of my patients had issues directly related to mental health. What I quickly began to realize that practicing in a silo was of absolutely no benefit to the individuals who needed the care. Fortunately, in Newfoundland and Labrador, in our rural communities, we had an interprofessional group of individuals who worked together. So my team included a nurse practitioner, a mental health social worker, a pharmacist, and other supports. And so we were able to sort of integrate the care and provide it to the individuals who most needed it, taking into consideration the importance of compliance with therapy, nutritional, personal needs, including hygiene, socialization, close follow-up. The most difficult aspect came with access. So if we needed to access care through a specialist, oftentimes that's where the barriers would build up. And over time, in central Newfoundland, we were very fortunate enough to build up a network with our specialist colleagues about an hour and a half away through virtual contacts, telephone contacts, or even the periodic visiting clinic that afforded us the highest level of care under the supervision of a psychiatrist. So in that kind of model, it worked well. But across the country, we see huge gaps, and these do need to be addressed because, unfortunately, many people who fall into this category end up being marginalized and end up extremely vulnerable and prone to multiple comorbidities.
What you say makes so much sense to me, and when I'm reflecting on the discussions about general health care in Canada and an increasing recognition, certainly within the federal government, but also in provincial and territorial governments, about the need to enhance capacity in primary health care. For example, more family physicians, more team members, counselors, mental health social workers in the primary care setting. And it sounds like you had been able to integrate some of those quality healthcare providers that have skills in mental health care right directly into a primary care setting.
That's right. We were very fortunate. And, our national college, the College of Family Physicians of Canada, has recognized the importance of an integrated approach to care, not only for mental health, but across a broad spectrum of chronic diseases. So this concept of a medical home where individuals from a variety of disciplines work together to assure the best possible outcomes. And for me in particular, the work that I did closely with my nurse practitioner colleagues, with the mental health social worker and the community health nurse was absolutely critical. Another important element was the work that we did in schools. So having a guidance counselor who could access you and meet with you on a regular basis to deal with a multitude of issues. We've seen a dramatic rise in mental health issues in our school-going population, relates to a variety of factors. And oftentimes that was one of the most neglected areas of care. So, the ability to sort of work together with a very strong foundational element in the school system and access to tertiary care through primarily virtual means saved us a lot of trouble.
It's interesting you mentioned schools. I spent many years trying to enhance capacity in schools through mental health literacy and other means. And one of the ways that there's good substantive data on this, is integrating primary care into school systems through youth health clinics. And there's a primary care nurse, counselors related to the clinic, primary care physicians come and go, sometimes pediatricians who do primary care. But this ability to cut across health systems and education systems using primary care as the vehicle meets young people where they actually are.
Yeah, and in my situation, oftentimes it was the robust and diligent care that came out of public health. The public health nurses who not only took care of the entire vaccination program, and interestingly, by this very sort of aggressive approach to vaccinations and working with the schools, the public health nurses picked up on cues where they felt there were individuals who might need alternative and supportive care. So I relied very, very heavily on my public health nurse team, but in particular, the work of the local guidance counselors and the clinical counselors that the school system provided.
Right. So what I'm hearing you say that if we focus to improve the quality of care and primary care, putting in resources, and that you don't need a heck of a lot of resources to what's already available,
Sure.
a little bit. We have an opportunity to reach not just young people, because we can go across school systems, but families and anybody who's in the community. That's the beauty of it. It's community-based, very early. And we know that early identification and early effective treatment, if you have a mental illness, makes a huge difference in your outcomes.
Absolutely. And so some of that sort of delves into the curriculum in our medical schools as well. I think the newer spiral curriculums afford us an opportunity to consider the very important aspects of students and residents learning about the importance of mental health with respect to their long-term goals in practice. And in particular, what treatments are effective, what's current, what's topical. For us as well, one of the positive features was having students and residents in our training program who spent time in rural communities and were able to directly manage or co-manage individuals who had mental health issues. The role of the community becomes very critical as well. So in my community, we were fortunate to have a lot of support from the Women's Institute, the church groups, and the local Lions Club in terms of things like Meals on Wheels, social programs, bingo, and a particular focus on those who were housebound, who were lonely, who may have comorbidities. And let's not forget that with an aging population, there is a significant concern about mental health in our seniors as well.
Yeah, I'm glad that you raised that issue because that is so important. The loneliness of seniors and the importance of healthcare visits to seniors. And that, well, if they have a primary healthcare provider, a capacity for a clinic, that can also give a nidus to coordinate other services that people may need. I mean, they may need specialized housing services, employment, social supports, Meals on Wheels, whatever. But that primary care focus in a clinic model deals with many aspects of mental health, not just mental illness.
Absolutely. And so one of the things I encouraged my trainees as well to do was to do home visits with me. Because actually being in the house and kind of getting a sense of the living conditions, the potential hazards, the nutritional element, the mobility, the hygiene, etc., become a very critical component of the care. We were fortunate in central Newfoundland to have, extremely gifted, hardworking community health nurses who sort of helped in this program. So if we identified an issue in a particular home, we could access an occupational therapist to go in and make modifications and at the same time, ensure that the physical and mental health components were taken care of simultaneously.
And it's interesting to hear you say that because when you were talking about your ability to move out of the clinic into the home, it struck me that this is what person-centered care really is about. It's that you're building the care around the needs of the individual instead of forcing the individual to meet a silo system.
And that's so crucial. And unfortunately, our current system and payment models and, the crisis with COVID has meant that the ability to practice in a truly integrated way has been diminished by the system we've created. And you and I have talked about the importance of remodeling. And I think we're beginning to realize from all of our national bodies that things need to change. But, in the historic cottage hospital system that we had, that I practiced in, and I was very blessed to practice in, this was kind of the norm. There was an expectation that you would do house calls. And often for me, not only were those the most sort of enjoyable and revealing parts of my care, but oftentimes, you'd come home with a loaf of bread and fish and a bottle of jam and a few of those kinds of benefits as well. So I very much encouraged all of my trainees to very seriously consider that important component of care, because until you actually see how someone is living and the potential challenges that they may be facing, all the advice that you give them might be for naught if you don't really capture that.
Well, two things that just struck me from what you've just said. One is that you were talking about in a smaller community, but that model can also fit into large urban centers. I mean, urban centers really are clusters of communities. Some are more integrated than others, but there's no reason that construct in improving capacity in primary healthcare delivery, you may even actually have more services that you can draw on. The local pharmacy, the Salvation Army, the barber or hairdresser who knows the people that come, and there is really a tremendous opportunity to if we increase the capacity for primary healthcare providers, whoever they are, physicians, nurses, pharmacists, whoever they are, to be able to give the care, identify people when they need it. I think we can go a long way.
You're absolutely right, Ian. And I think, this is sort of very much the current discussion model. How do we switch from, office-based practices that are very much silos to this integrated model of care, a sort of a one-stop stopping model? It's worked very well in certain rural communities, and it has worked well in urban centers, in academia, etc. The other areas that I've often thought about is the issues of mental health in our immigrant populations,
Mm.
the many issues that individuals who face systemic racism or marginalization, mental health issues that come in individuals in the LGBTQ community, our indigenous brothers and sisters. And so those are areas that we, certainly from the academic viewpoint, that we focused on. And you might want to just elaborate a little on that, Stan, from your experience.
Well, those communities tend to be hard to reach for multiple reasons. Everything from language and culture to be able to transportation,
Right.
to large amounts of stigma, to distrust of, and sometimes obviously well worth distrust of the healthcare system. And it's really important that, because if we have primary care capacity reflect the community in which it is delivered, that to me would make a big difference in welcoming people to care and in providing that care. But the bulwark of that is investing in the foundational capacity of primary health care and not putting mental health care in a silo somewhere else, so that it still remains out of sight, out of mind, but making sure that everything comes together.
Absolutely. And I think that's where that relationship between the primary care provider and the specialist psychiatrist is so critical. A free two-way ability to converse, to dialogue. In my practice, very rarely did I have to access the help of a psychiatrist sort of on an urgent basis, except in 2 or 3 instances in the year. But if you knew you had someone who had your back and was willing to help out in those situations, it made a huge difference. Time and again, I hear that this access issue, the ability to get someone in to tertiary care or secondary care in a crisis situation, has always become a problem. So you're absolutely right. A more robust primary care model would minimize those risks for the community at large, and also reduce the burden on the providers. Working in a team-based environment, I was so fortunate to have 3 nurse practitioner colleagues, and each of them had, they had very good generalist practice, but each of them had developed certain skills in chronic diseases and become very expert in areas of counseling and providing the type of care that perhaps sometimes I didn't have, just given the busyness of the day. So more and more, the ability to sort of diversify this integrated model of care, and to place reliance on individuals within your team who have superb skills to provide the best outcomes for this very vulnerable group of individuals is critical.
Yeah, I think you hit on a really, really important point there, and that is the composition, the makeup of the primary care team. Now, we know, for example, that psychotherapies are effective. We also know that they need to be provided by people trained in their use. You don't have to be a psychologist to provide psychotherapy. Many people who are counselors or have a nursing background or a social work background learn and become fantastic therapists using evidence-based therapies. One of the simplest ways of enhancing mental health care and primary care is to ensure that every primary care clinic has people who have psychotherapeutic skills as part of their workforce.
Right. No, and you're absolutely right. And I was also astounded at the level of psychotherapeutic care that came out of, some of the very robust and talented high school support systems that exist, across the country. The guidance counselors and their ability to delve into these sometimes often complex mental health issues. We've seen a significant rise, for example, in ADHD, autism, and if you're not able to provide the appropriate care, the situation can become so very disruptive for the entire school body. So, Stan, what about your experience in those types of situations?
Well, exactly. It's very similar to yours. I mean, I have had the privilege to work with school counselors across this country, coast to coast to coast, and in multiple other countries around the world. And these are people, if they have the solid counseling skills, and they get those counseling skills, because they see so many kids in a year. They see hundreds and hundreds and hundreds of kids very clearly and quickly. And same with teachers, they can notice what's happening to these kids, and then they can link with primary care providers, nurse practitioners, physicians, whoever, and you can create that. In a project we did in Malawi and Tanzania, we created a hub and spoke model where we trained the community health center with all the clinicians, and then put schools and link them all to the community health center, and it works really, really, really well. But that's just a simple-minded approach to enhancing the capacity, and that approach could work in the Canadian context everywhere, because the model of how it actually works is not set in stone. It can be modified to the community that it's in. It may be a hub and smoke model isn't the best for downtown Toronto, whatever, but it can be modified. But the key component here is to have robust primary health care, and the people within the primary health care system have to be able to have the competencies. That's so important, the competencies to deliver psychotherapeutic services.
No, you're absolutely right. And, we were very fortunate, again, through Memorial University, we had a number of training programs for individuals who were interested in doing cognitive behavior therapy. Greg Dubourg runs an excellent shop with respect to that. And I've had the privilege of attending some of his sessions and then bringing back some of my teachings back to my colleagues. But, as time evolved for me in practice, that became a crucial element of my day-to-day work. We quote figures of 13, 15%, but at the end of the day, for me in my practice, as my practice aged with me, I would say a full third of my individuals needed some kind of mental health support. Sometimes it was just simple reassurance, the importance not to label someone, to distinguish between what is a normal physiological response as to something that becomes pathological. Have you noticed that through COVID, we've seen sort of a lot of discussion about this, and then perhaps people being labeled when perhaps it wasn't necessary and it was just a response that was kind of normal as opposed to pathological?
Yeah, I think we've seen a lot of confusion during COVID with normal, expected emotional, cognitive, and behavioral responses to existential threat, and confusing that with a mental disorder requiring treatment. It may require support for sure, or skill sets and cognitive capacities. And you're talking about people who may need to learn some cognitive capacities, some skill sets of dealing with the challenges that they're facing, instead of labeling everything as pathology and running to seek treatment. And that can be very well done in the primary care setting. And we've talked about primary care as a place where people, we call this group high volume, low acuity, or low intensity. So that's a doctor talk for lots of people who have mental health care needs, but they don't need to be in a hospital, right? But
Right.
there's also that other group of people who have serious and severe mental illnesses.
Right.
And they have to go to hospital, but something when they leave hospital, they need good care in the community. We fall down there all the time, and primary health care providers can make a huge impact. And there's that model called collaborative care. You mentioned a little bit about it earlier, where psychiatrists and other mental health professionals link with primary care practices to provide ongoing support and mentorship and actually intervention.
Yeah, and for us, that was a critical element. There was always that period of, anxiety and fear when someone had just been discharged from a mental health unit and were coming back home. They themselves were facing challenges. The family were very nervous that there might be another breakdown.
Right.
And really, this is where our community health nurse and mental health social workers were such a huge asset, assuring compliance of medications, making sure that things with respect to, oftentimes it was injectables every 2 or 3 weeks. So that gave them an opportunity to actually go in the home and assure that the parameters that needed to be monitored were being monitored, and then to collaborate with the team of physicians and nurse practitioners as well. But historically, that's an area where we did fall down. And at times, when we were having staff shortages or whatever, this is when you ran into trouble, where someone had been discharged, they came home, they kind of got lost to follow up, and then the next thing was a crisis down the road. And when this cycle repeats itself, it's particularly difficult on family members and loved ones. And I'm sure you've certainly seen that.
Oh, yes. Oh, you're absolutely so right. And, one part of that, for example, is that we know that for people who have been hospitalized, say they've had a suicide attempt as part of their struggle with an illness, and then they've been hospitalized and they're stabilized, and they're feeling better, things are becoming more integrated, and then they're discharged from hospital. We know that period of right after discharge is a huge risk period for suicide. And we also know that one of the most important things that we can do for people is to provide human connection, because it's the human connection that actually is the foundation for the human condition. And we forget that. And that's really bad. But so an integrated system of collaborative care, where individuals who have had to have higher acuity needs met in a hospital setting or some kind of tertiary or secondary setting, when they can be transitioned to the primary care clinic, the primary care site, much more effectively.
Yeah, and this is why access is so important. And when you talk about millions of Canadians now without a primary care provider, I think we not only as politicians but as physicians really need to look at evolving models of care to ensure that that base access is not denied our citizenry. Added to that is some of the world flashpoints and the crises that we're seeing mean that individuals are coming to this country with a significant amount of trauma.
Right.
I mean, it's heartbreaking to see what's happening in Ukraine today. And Stan, for you, I know it's particularly emotional given your own family connections to that part of the world. But I know in St. John's, Newfoundland, we have established what's called a gateway program to help new immigrants adapt to life and provide the necessary medical care. But an integral and critical part of that care is the mental health support that comes with individuals who have lived in war zones or have come through very traumatic experiences as refugees.
Well, you raised a couple of really important points there. I just want to sort of let you know that make total sense to me. If we have a primary care healthcare system that is welcoming and is functioning, we can meet those needs better, for sure, no question about it. The other thing that you just raised is that federal governments and provincial governments have woken up to the fact that primary health care is a problem. And people around this country are saying, gosh, we have to fix, we have to improve, enhance, make primary care better. So while we're doing that, why don't we just integrate mental health care into a better primary care? We have to do it anyway. We have to do it anyway. We have to train physicians and nurse practitioners and bring in counselors. And so we have to do it anyway. Why not just do it all together at the same time? It's a wonderful opportunity.
No, I mean, that really does make such good sense. And I think increasingly the consensus is that is the way to go if we're going to fix what's increasingly looking like a broken system. So, Stan, this has been, wonderful. I thank you for for the invitation, and thank everyone who's online for attending today. Were there any final wrap-up comments you had?
Well, very briefly, Mohammed, I think we can enhance the delivery of mental health care through better integration and enhancing the capacity in primary care. I think that's just a given. I think it's time to end the silos. You shouldn't get your mental health care here and your physical health care here. This should all be integrated, and primary health care is the foundation of our healthcare system.
Thank you so much. And thank you to the audience. It's been a pleasure.
And thank you very much, Dr. Senator Ravalia. I'll see you in a few minutes
You will
down the
indeed.
street.
For
All
sure.
right. Okay.
Thank you.
Take care, everybody. Thanks, audience, and thanks, people, for
Thank
listening.
you.